In this next part of the lecture, we're going to talk about some of the most common pathology that we encounter in neuroradiology. This is a CT of the head, and it's a little hard to make out some of the features. Something's gone wrong right here, and there are all these lines starring out from a point right here near the eye. This is what happens when something in the body is so radiodense, absorbs so many of the X-rays that essentially none get through. This really messes up the mathematics that we use to create a CT image, and that's why you get this starring artifact. What could be so dense that it absorbs essentially all of the X-rays? Metal. That's what's so dense. This is actually a small sphere of metal, and everything else out here is normal. It's just been obscured by that metallic sphere. This is a BB in someone who got shot by a BB in the eye. Remember this picture when we talked about the 3 layers of the meninges and how it divided the intracranial vault into 4 different spaces? The dura, the arachnoid, and the pia mater divided the intracranial vault into an epidural, subdural, subarachnoid, and intraparenchymal components. We're going to take that now and actually make use of it when we talk about intracranial hemorrhage. The way it works is when you hemorrhage inside your skull, you're going to be in one of these 4 spaces. And figuring out which space you're in can help determine what caused that hemorrhage. So let's go through the different spaces. Here is a clot. And you can see that the clotted blood is much denser than the normal brain. Not as dense as the skull, but much denser than brain. So we're going to try and figure out where this clot is, and the way we're going to do that is we're going to use the configuration of the hemorrhage. Notice that this hemorrhage creates a convex surface against the inner surface of the skull, but it also creates a convex surface pushing hard against the brain. It's pushing so hard because it comes from an arterial source and it's under great pressure. And that happens in the epidural space. So when you see a hematoma that has 2 convex surfaces, a biconvex or lentiform configuration, that indicates that we are in the epidural space outside the dura. Here's a different type of hemorrhage. This hemorrhage, although it is still convex relative to the skull, it is now concave relative to the underlying brain. This clot is not pushing nearly as hard upon the brain. That's because it's a venous injury and it occurs in the subdural space. So when you see a crescentic configuration to hemorrhage, you know you're in the subdural space. Interestingly, subdural hemorrhage also can track along the dural reflections. And by dural reflections, I mean the falx cerebri and the tentorium cerebelli. So if you see blood right along the falx, that's also in the subdural space. Here's an example of a subdural hematoma tracking along the tentorium cerebelli between the cerebellar hemispheres and the occipital lobe. Here is an example of hemorrhage in a different space. Here the hemorrhage is filling the ventricles and it is following along the sulci. Normally, we should see the sylvian fissure here. It should be dark like the other water that we're seeing here, the CSF. Instead, it is replaced by this dense material. That's the clotted blood. And you can see it up front, following along the sulci. When you see these finger-like projections of hemorrhage extending down from the surface deep along the sulci, you know you're in the subarachnoid space. After all, the subarachnoid space is where the CSF normally lives. And so when the CSF is replaced by hemorrhage, it has the same configuration as the CSF would have had. Notice also that the basal cisterns are completely filled with blood, and this star configuration of the basal cisterns is characteristic of a subarachnoid hemorrhage. The last compartment that we're going to be in is parenchymal hemorrhage. Here you can see that this hematoma is completely surrounded by brain on all sides. That's what lets us know that it is in the parenchyma itself. It is below the pia mater. It is an intraparenchymal hemorrhage. Now, this is not just an academic exercise for radiology residents. Being able to attribute a hemorrhage to a particular compartment in the brain really helps with the differential diagnosis. For example, in the setting of a subarachnoid hemorrhage, and if the patient does not have trauma, you'd be very worried about a ruptured berry aneurysm. Whereas in a parenchymal hemorrhage, you might be more worried about a bleeding tumor. As another example, if you have a patient with trauma and you find a subdural hematoma, you might watch that for a little while because you know that it came from a vein and it's not likely to suddenly get bigger. So you just watch it with sequential CTs. But if you see an epidural hematoma, that's under arterial pressure and that is very likely to get worse in a hurry. So that patient goes straight to the operating room. This is a disease called hydrocephalus, in which the ventricles become enlarged. Now, wait a minute, you're saying to yourself. You just showed me a couple of pictures of a 19-year-old and a 90-year-old brain, and you said it's normal. So why is it that this patient with large ventricles has hydrocephalus, but that 90-year-old with large ventricles doesn't? I'm giving you a second to think about it here. Well, recall the picture of that 90-year-old. It wasn't just the ventricles that were enlarged. It was also the sulci that were enlarged because the brain was atrophying and the CSF was taking up all that extra space, both ventricles and sulci. In this case, the ventricles are enlarged, but the sulci are compressed. So this is not just atrophy of the whole brain. This is entrapped CSF within the ventricles that can't go out and get reabsorbed, and it is expanding the ventricles. Here's another example of hydrocephalus, this time on an MRI. You can see how big the CSF space in the ventricles is, but where are all those bright sulci? You can barely make them out. Most of them are completely compressed. This is another example of hydrocephalus. This also shows another manifestation of hydrocephalus, which we call subependymal flow of CSF, and it creates these little caps of abnormal signal surrounding the edges of the lateral ventricles. In this patient, we have an area of brain that's abnormal. This is the normal brain parenchyma. This is about how dense it should be, and you can see that there is this wedge-shaped or triangular in cross-section area of abnormal attenuation of brain parenchyma. It's too dark. Why is it too dark? It's too dark because there's too much water there, and if you mix some of this dark water in with the brain, then it becomes darker on average. So why are there these nice straight lines separating the normal brain from the abnormal brain? I thought nature didn't make straight lines. Well, nature absolutely makes straight lines, and this is why. This is a diagram of the vascular territories within the brain. And you can see that the anterior cerebral artery is responsible for this blue territory up front, and the middle cerebral artery is responsible for this lateral area out here, and the posterior cerebral artery is responsible for the red area here. Let's take this concept and apply it to a CT scan. So here's that same CT scan that we were looking at, and we're going to apply the vascular territories here. So the anterior cerebral artery territory is outlined in blue, and the posterior cerebral artery territory is outlined in red, And the middle cerebral artery territory is outlined in yellow, and that's what's abnormal. That's why we have these straight lines, is that they demarcate the different vascular territories supplying the brain. So what happened here? This middle cerebral artery vascular territory is completely devoid of blood flow. And this brain has died and become edematous because the vessels that normally feed the brain can no longer contain the blood completely. And there is a flow into this area, and we call this cerebral edema. How does this happen? This happens because a clot occludes the middle cerebral artery. Here's an angiogram from that same patient. You can see the inflow from the internal carotid artery. We know that this confusing thing is just the carotid siphon, no big deal. We come up on this frontal image to the carotid bifurcation, and the anterior cerebral artery is flowing beautifully. In fact, you can even see the anterior communicating artery, allowing some contrast to flow into both of the anterior cerebral arteries. But here is the middle cerebral artery, and it starts out okay, but then the middle cerebral artery gets to about here, and it completely cuts off. There's no flow past that point. Complete occlusion of the middle cerebral artery by thrombus. This is thrombotic stroke, and the entire middle cerebral artery has, that entire territory is infarcted and now is dead brain. There are other types of strokes besides the thrombotic stroke we were just talking about. This is a different type of stroke, and you might ask yourself, well, which of the vascular territories are these strokes in? And it's not clear, right? It's right about where you'd expect the middle cerebral artery to end and the posterior cerebral artery to begin. The other interesting thing is that it's perfectly symmetric. Both sides are affected. These strokes are called watershed infarcts, and they occur right at the borderline between one vascular territory and another vascular territory. They don't occur because one of these arteries is occluded. They occur because the entire vascular system is under low pressure. And thus, neither one of these vascular territories can quite reach this intermediate zone, this watershed zone between the vascular territories. And that's why you get these symmetric watershed infarcts. Here's another type of stroke. Sometimes it's just a tiny little artery that gets occluded by atherosclerotic disease, and that artery creates a tiny little stroke. Pathologically, when we cut open these brains in cadavers, we see little lakes inside the brain, and so these are called lacunar strokes, and they are a result of microvascular disease, tiny arterioles that are affected by atherosclerosis. This next CT scan is sort of a pop quiz. I want you to think about this image and see if you can figure out what's wrong. This is a 78-year-old guy who came to the emergency department because he wasn't responding to his family. So go ahead and pause the video right now and think about what you think is wrong with this image. So there's a couple things to notice here. One is that we talked about the difference between a 19-year-old brain and a 90-year-old brain. This 78-year-old guy should be a lot closer to the 90-year-old brain. He should have big ventricles and he should have large sulci. His sulci are completely inevident here. You can't see them at all. And his ventricles are really small, like that 19-year-old. That's not normal for a guy who's 78 years old. Here's another thing to notice. You can't see that ribbon of gray matter that's supposed to be going all the way around the outside of the brain. And you can't see the gray matter that should be in the basal ganglia. It's all washed out. That's because this entire brain is like that triangle of the middle cerebral artery that we saw in the stroke. This is an infarct of the entire brain. This, unfortunately, is brain death. Here's something that can go wrong in the brain when there is a mass or something else causing a mass effect within the temporal lobe. The medial portion of the temporal lobe is called the uncus, and that uncus should be along the lateral aspect of the tentorium cerebelli, which is right here. If a piece of uncus flips over the edge of the tentorium cerebelli and crushes the brainstem, we call that uncal herniation, and this can be a devastating event for the patient. You can injure the third cranial nerve and cause the pupil to expand, and you can cut off brain supply to the blood supply to the entire posterior circulation. Here's an MRI in the sagittal plane of a patient with a chronic disease. You notice anything about this that differentiates it from some of the other examples I've been showing? Well, one thing to notice is how thin the corpus callosum is. It's thin and it's ratty and irregular, much thinner than that nice normal one I pointed out in the first half of the lecture. This is the same patient, and you can see on this FLAIR image, which is a type of T2-weighted image, you can see abnormal white matter all the way around the ventricles. In fact, these are oval plaques of abnormal white matter that have become confluent and flowed together, and you can see finger-like projections of abnormal white matter extending out to the periphery of the brain. This is a classic example of an inflammatory disease of the white matter called multiple sclerosis. This is a coronal image. I haven't shown too many coronal images so far. This is a coronal image of the brain. This one is T1 weighted, and there is contrast, gadolinium-based contrast that's been administered to this patient. So we can look for areas of abnormal enhancements, which would be bright. In fact, here is such an area. There is a rim of abnormal enhancement around this lesion in the temporal lobe. There are a lot of things that cause enhancement within the brain. Tumors can cause enhancement. Infections can cause enhancement. There is a long list of abnormal things. This one happens to be an infection that occurs almost exclusively in patients who are immunocompromised by HIV. This is toxoplasmosis, and this is a little abscess of toxoplasmosis in the temporal lobe. Here's another type of infection. This type of infection is very particular about what part of the brain it affects. So I think the thing to notice on this FLAIR image is the asymmetry in the temporal lobes. You can see this one's normal, this temporal lobe is normal, but on this side, the medial part of the temporal lobe is abnormal. There's one particular infection that focuses on the medial aspect of the temporal lobe, and that's herpes. This is herpes simplex virus encephalitis. We'll show a couple examples of pathology in the spine. This is an MRI of the lumbar spine. This is a T2-weighted image in a sagittal plane. Remember on the normal images how we talked about how nice and smooth the posterior longitudinal ligament was going to be as it came down behind the vertebral bodies and discs? Well, in this patient, it's nice and smooth until it gets to about here, and then it bulges out and around this little ball of tissue. That little ball of tissue came off of this disc, and that is a disc herniation. It is severely narrowing the central canal and crushing these nerves in the cauda equina. You can see on this axial T1 weighted image, this is the herniated disc taking up all the space that should be available to the cauda equina within the central canal. Here's another pathology within the lumbar spine. Remember we talked about how the lumbar spine consists of vertebral bodies alternating with discs. So you have vertebra, disc, vertebra, disc, vertebra, disc, and then something's missing right here. And then you go back to your vertebra, disc, etc. What happened here to this vertebral body? Well, this vertebral body was entirely replaced. Right? It's not filled with its normal marrow anymore. Instead, it's been replaced by tumor cells. This is metastatic disease in which the metastasis has completely replaced the vertebral body and expanded out into the central canal to narrow the central canal and crush the cauda equina. Metastatic disease. And that's our introduction to neuroradiology. We'll return with some additional case-based sessions later in the course.